First of all, I'm thankful to my dear friend Gihan, the president and the council for inviting me to do this lecture. He wanted me to do something interesting on an update for old age. Then he's the one who decided. I thought there are a lot of young people who will be benefited by learning about dementia, and some of us who are getting older will also benefit by learning how to manage it better ourselves, what is working and what is not working. See, this is the update. I'll go the first part, the assessment part, bit faster, because we all know that early recognition is very important, mainly for counseling purposes and assessment of secondary or treatable causes, and advanced care planning and consideration of medical therapy. So, unfortunately, in Sri Lanka, a lot of people come quite late, and that really affects the prognosis of the cases. So, a tinge of suspicion in anyone who's presenting with memory impairment, any cognitive impairment is important in clinical practices to prevent advancement of certain dementias. This is the diagnostic worked out that is established all over the world. First of all is establishing the correct diagnosis of dementia and determine the severity and looking for etiology, treatable causes, and assessment of risk, assessment for other associated problems. So, there are a lot of trainees who your assessment has to cover, diagnostic workout actually has to cover all these areas. So, it's a big area. I won't be able to cover it in 30 minutes, but I will try to address. Now, other thing is actually not every cognitive impairment is dementia. Cognitive impairment is not synonymous with dementia, and you have to carefully exclude other things like delirium, depression, and it's also normal to have certain level of memory impairment and new learning and reduced speed with aging. And we need to remember, mild cognitive impairment is not at the earliest stage of dementia in every case. The conversion rate to any form of dementia is actually 10% per year. So mild cognitive impairment can be pretty normal. That is the understanding current now. This is the diagnosis of dementia and DSM-5 and ICD-11. The major neurocognitive disorder is significant cognitive decline in at least one of the cognitive domains, complex attention, executive function, language, learning and memory, perceptual motor, or social cognitions. The decline must be based on both subjective and objective finding. This is the area that actually lacking in our part of the world, that we don't really objectify the cognitive impairment in our assessment. I'll come to that in later. And it should interfere with instrumental activities of daily living. Then one can also have minor or mild neurocognitive disorder without dementia. We call it the comprehensive assessment of dementia nowadays, and it should encompass all these areas of history, mental state examination, physical examination, appropriate investigation, cognitive assessment, functional assessment, social assessment, and other aspects of assessment. So it's a very detailed out assessment. But I thought because of the completion, the history has to be very thorough. And this is one area that a reliable informant is essential. And timeline of symptom presentation, pattern, and rate of progression actually gives an idea of what the dementia is. And similarly, cognitive domains affected itself suggest the type of dementia. Then functional impairment, both subjectively and objectively, and depression, other behavioral and psychological symptoms, risk factors, medication, risk assessment, education level, social, ethical, legal issues, you name it, or dementia. Technically, you can't do one assessment within one day. It's an ongoing assessment process. Dementia this is the difference between. So tentatively you can diagnose, have a differential diagnosis by taking the history, but you will not be able to come to a conclusive diagnosis, even a working diagnosis with one session. And establishing functional impairment is one of the key factors in identifying dementia. A good history on the patient and reliable caregiver, family member is good enough, but it has to be complemented by validated tools. These are some of the tools that we use, like the Bristol Activities of Daily Living, Alzheimer's Disease Functional Assessment Scale, Disability Assessment for Dementia, right? To establish the functional impairment, we also can go do the basic activities of daily living and instrumental activity of daily living. I will not read it out, but I'm sure all units that do dementia assessments carry out this. And now one need to understand the severity of dementia is based on functional impairment, not the domains of cognition impairment. So one can be very poor memory, but can be quite functional. So based on the activities of daily living functionality, we will be labeling them as mild, moderate or severe. Not based on screening tools either. So screening tools I'll come, or there are other tools to assess the level of dementia, but none of them are quite useful in clinical practices or even for legal practices. Then one thing that is actually more important in our part of the world, the majority of patients come to us because of the behavioral symptoms, psychological and behavioral symptoms of dementia. And it constitutes the major component of the dementia symptoms, irrespective of which subtype. This is unfortunate. So because of the lack of awareness, they come with this. And these are the type of behavioral symptom clusters that come. One can get apathy, depression, agitation, aggression, psychosis, mania. So late onset, any mania can be actually dementia. Late onset aggression, one need to screen for dementia. Agitation, depression, these are well known established fact, but most of the time we miss it. Early dementias can purely present with BPSD symptoms. It's associated with, BPSD is associated with greater functional impairment, institutionalization, accelerated dementia progression, and data caregiver stress, poor quality of life, and increases risk of death. More neuropsychological markers of dementia are there whenever they are associated severe behavioral and psychological symptoms of dementia. Now this is, again, I thought of emphasizing more, the Cache country study in memory and aging, the 1 month prevalence of neuropsychiatric symptoms. Cognitively normal at old adults, 15% of them had it. Cognitive impairment to no dementia, 31%. And dementia had about 60%. So just because of there's, now this is making more difficult. Just because there's behavioral and psychological symptom, it may not be dementia either. The old age is becoming more difficult as you refine and update more. This is our NIMH clinic. We have been kind of auditing our patient numbers, and we see large numbers have delusions, hallucinations, but after listening to my dear teacher, Dr. Abesing, I think some of the hallucinations can be normal. Again, so, but I didn't know that time. And irritability, it continues to be there. So we have to be careful, but then you have to have a differential diagnosis. So it's, when I was talking about geriatric medicines, they tend to think one diagnosis in aging people, whereas we psychiatrists have to have a bigger differential diagnosis in old age. And differential diagnosis can be even for dementia big. Around 40%, 1% is Alzheimer's, vascular dementia, then mostly PD, if there's more visual hallucinations than auditory hallucination, and DLB with more hallucination, delusion, and it could be delirium. We tend to forget also subacute delirium. That is delirium setting very slowly, and it not clearly apparent. And Parkinson's disease had complex health, and Huntington. These are major ones, but it actually, once you work out only, you will understand it's huge, right? And then assessing etiology for treatable cause, it's very important to have a very good history and examination and do appropriate investigation based on your history and examination findings. Other aspects to assess, and we tend to forget most of the time, is ability to drive and capacities. Recently, I came to Nigamdu 2 weeks back for a case that I assessed 2011 for capacity. Retrospectively, they asked. And legal issues, elder abuse, social and financial status, home environment, caregiver assessment, availability of services and support, and physical examination almost always depends on medical comment and could be normal, but look for features of reversible causes. Hypothyroidism is common in this part of especially among females. Now the understanding is hypothyroidism prevalence above age of 60 to 65 is 10 to 15% among Sri Lankan females. So, neurosyphilis, intractable tumors, normal pressure hydrocephalus are also reversible causes. Look for cardiovascular, cardiometabolic risk factors, look for physical complications, bed sores, infection, disabilities, hearing and vision. Further evaluation of cognitive impairment has to be done once you suspect that the patient could be having dementia or if there's a comorbid dementia, right? And MM is the most commonly used cognitive evaluation tool. It has good sensitivity and specificity, and Montreal Cognitive Assessment of MOCA, again, is excellent sensitive for detecting mild neurocognitive disorder. Both MMSC and Montreal Cognitive Assessment are validated and highly used in our setups. And Minicog is also validated in Sinhalese, but it's highly sensitive, but specificity is slightly low. But remember, these are screening tools. Sometimes in our busy practice, they also help you to categorize the mild severity, but they are not concluding test. They are screening and kind of for service-oriented purposes, they can be used to label patients. Right? But normal scoring cognitive testing cannot rule out dementia. We have seen many cases like that. When uncertain, more extensive neuropsychological testing is recommended. Now, I think that's why either you do it extended cognitive assessment, or in Sri Lanka, we are licensed to repeated battery for assessment of neuropsychological status for the last 2 years. Through the college, we have the original Pearson RBANS tools in our unit, and all the few other cognitive tools, they are validated. And this tool is very interesting tool. It's a brief individual test measuring attention, language, visuospatial, constructional abilities, and immediate and delay memory. It actually is capable of differentiating what is Alzheimer's, what is vascular, even late onset psychotic illnesses, schizophrenia-related cognitive impairment, everything can be that. So you all are invited to learn and use it through our Digayu old age clinic. Then investigation, biochemical, radiological and genetic investigation only modestly increase the diagnostic accuracy for common dementias. Important for ruling out rare and treatable causes, laboratory testing, full blood count, comprehensive metabolic panel, TSH, vitamin B12. So they all are important because the B12 deficiencies are again common due to religious reasons that are prevalent in Sri Lanka. So we sometimes supplement B12 and they rapidly improve. Consider other laboratory testing based on specific concerns only. Then structural neuroimaging. Now, actually almost all the guidelines recommend routing structural imaging. But this first recommendation was by the Americans, and neuroimaging helps to rule out treatable causes, STH, tumor, NPH, treatable mass, and certain subtypes of dementias. MRI without contrast media is preferred. And if you are ordering it, you have to go, the type that you order, the MRI brain dementia protocol. That's for normal screening. And it actually volumetric assessment of the hippocampal formation and give an idea whether it's actually Alzheimer's or non-Alzheimer's. And CT without contrast when MRI is not available or contraindicated can be used effectively. This I'll show you a few pictures from our case. The multi-infarct dementias we have seen, CT versus MRI, then normal pressure hydrocephalus, will not go details, CT scan of mixed dementia with white matter changes and lacunar infarcts, and specialized investigation. They are not usually recommended for routine practice, but they help diagnosis subtypes and it to change management. Diagnosis is uncertain, we have also again go for specialized investigation. And CSF testing, I think some of my trainees are here. We have done thorough testing when we were there. It rapidly progressive symptoms, CSF prelocytis, CSF IG index, oligoclonal band might indicate an autoimmune disease. We have cases, they detect a few cases. Even 2 months back, we detect one. And prion disease test for CSF 14 and 13. We cannot do that in Sri Lanka, unfortunately. But post-mortem, we did a few cases. Some of them came, almost all of them are negative. And it's better to liaise with the neurologist at this stage. For Alzheimer's disease, these are for academic purposes. None of them are done in Sri Lanka. But this Alzheimer's screening biomarkers can be false positive in very old, so they don't have a real clinical value in day-to-day practices. For academic purposes, I included, though the NICE mentions them. And functional neuroimaging. Now, functional neuroimaging is used in some of the high-tech centers, mainly fluorodeoxyglucose positron-emitting tomography. It's not available in Sri Lanka, but in India, Singapore, it's available. It predicts development of AD in patients with MCI, useful in staging ADI. This is the thing, if somebody is even scoring very low in their cognitive assessment, we say somebody is interested in whether they are actually losing their cognitive functions, one can undergo RBANS and maybe perhaps Brown's attention scales. Right? In Sri Lanka, both those scales are actually available in our NIMH as well as in private sector. But still they are normal or inconclusive, so one can actually go to Singapore and get it done. Or Mumbai, right? Then perfusion SPECT. SPECT scans are available in Sri Lanka in the private scan, but for legal purpose, I have only watched 1 or 2 actually. Then amyloid PET, mainly for research interest, but again, it does not correlate well with symptom severity. Negative scan can exclude AD and also can differentiate from frontotemporal dementia. This is the interesting. So, especially there are a lot of medical legal issues and issues related to capacity. These things can become handy in very high-profile cases. Then functional neuroimaging continued, especially Lewy body dementia, Parkinson disease. It's become useful. I'm not going to read everything, but the important thing is, now you all must have seen some of the cases of vascular Parkinsonism had been labeled, right, as Parkinson disease, and they have also vascular dementia features. And neurologist starts levodopa therapy, and the person goes berserk, right? I can see the very senior psychiatrist now. So that is a very terrible situation. But this is where the functional neuroimaging, why almost all the Lewy body dementias now, before starting levodopa therapy, they do functional neuroimaging. It actually helps them to identify whether necrostriatal pathway is intact, and whether any vascular lesions are existing or non-existing. And FTG PET is the kind of a more clinically used one. Signal patterns of hypermetabolism associated with specific clinical syndromes can be also used in frontotemporal dementias. The frontotemporal dementia is a very difficult situation to identify because there are many subtypes of frontotemporal dementia, very rapidly progressing and very clinically challenging for any psychiatrist who are trying to handle the BPSD. So now they suggest functional neuroimaging with early onset frontotemporal dementias. Then genetic testing is not recommended in clinical practices, but I thought of mention for research. But the NICE continue to mention genetic testing should be considered in patients with multiple family members diagnosed with AD at a young age in an autosomal dominant pattern. Because they can actually, in most of the developed countries, they become entitled for social benefits at a very young age. They can retire early. Then EEG, many appear normal in early disease of irrespective of the type of dementia, and slow enough reducing EEG complexity and syndrome can be seen in disease progression. It's only a biomarker, not mainly used, but I'll come to rush to the management. Management is mainly pharmacology and non-pharmacological. Alzheimer's disease. The first line is acetylcholinesterase limiters. It delays the onset of neuropsychiatric syndrome, but not effective when it has agitation. Then memantine may reduce the development of agitation, but will not reduce if the agitation is already started. And treating neuropsychiatric symptoms, as you know, psychotropics, depending on the behavioral and psychological symptoms of dementia. Then frontotemporal dementia is the more challenging type. We psychiatrists and the world still accept we are helpless in there. So counseling, education, stimulation activity, safety, advanced care planning is the main line of treatment. Pharmacological treatment, no memory enhancers work. But we sometimes try, maybe they are actually misdiagnosed, but treatment can be tried to handle the behavioral and psychological symptoms. And when you read the Oxford and other articles, they say protein-specific. These are trials still. Now, some 1 or 2 promising trials, leurocelide, very rare drugs. But I try to search whether anywhere well the worst. They are in Japan, they are trying. That's the only country. Then vascular dementia, important to identify vascular dementia correctly because no medication specifically approved by the FDA. And multi-infarct concept led to use of vasodilatation, most widely produce minimal effect and risk factor modification. Now one of the beauties of the lifestyle changes and modifying vascular risk is almost all the cases of vascular dementias, the progression can be halted, slowed down, if you address them very carefully. And homocysteine and cobalamin interaction has to be very careful because when you are in vascular dementia, a lot of dietary supplements are recommended to reduce the progression. You will understand now the citicoline had come, then there are B complexes, homocysteine supplementation, CoQ10 supplementation, everything. Though the vascular dementia progression can be reduced, it's a very expensive business. With the lifestyle modification plus the supplementary and dietary modification itself is very, very difficult. Then Parkinson disease dementia, pharmacological treatment, dopaminergic medication, acetylcholinesterase medication, non-competitive NMDR antagonist, non-adrenergic medication. Because of acetylcholinergic medication, they said rivastigmine has slightly better, but again the evidence is not very clear. And there are a few emerging treatments. Will increase the focus on modifying underlying mechanism associated dementia and cognitive decline, enhancing neuroprotection, facilitating neuroplasticity. Now they are talking about neuroprotection for all the Parkinson disease patients, early start of agonists and antioxidants, any Lewy body disease, that may work. And managing BPSD, I thought I'll focus a bit, pharmacological and non-pharmacological again. And the recommendation is almost all the guys behavioral measures should try it first. Then antipsychotic, risperidone, aripiprazole and quetiapine is approved by many organizations worldwide to treat agitation. Then SSRIs. Management of apathy, evidence is very limited. This is where maybe your grandfather is very poorly split, you can use their PlayStation to stimulate the grandfather, grandmother. That works, according to the research evidence. Now, I actually got fascinated. It's not a bad idea to start playing games at old age. And OT activities. So I suggest also senior, when you are getting better, we should buy a PlayStation. There's good evidence to support that. And smart devices perhaps. And OT activities, stimulation, creative activities, cooking, Montessori methodology, so that we had to start doing all the things that we were doing childhood. Then pharmacotherapy for apathy is quite difficult. Acetylcholinesterase inhibitors, not that. But one moderate improvement is methyl for methamphetamine, the so-called the drugs that child psychiatrists are using more, is sometimes give promising results. So when behavioral management for apathy is, I think everything child psychiatrists are doing with their patients, learning disabilities, attention deficit disorders may work. Antidepressant mixed results, I will not go for details. And management of anxiety, anything that works for young age, for anxiety, is likely to work for elderly. I will not place because the time constraint. One of the things actually very establishing and restoring the sleep and sleep hygiene has no one to reduce anxiety in elderly. And good therapeutic relationship, education, relaxation training, CBT and behavior therapy and medication. So anxiety again predicts poor prognosis of the whole syndrome. So addressing them is actually quite important. Again, the management of mania, one has to do thorough evaluation, and low-dose antipsychotics are recommended. Mood stabilizers, all types of mood stabilizers work, but very cautious use of lithium is recommended. Interestingly, these can be completely dementia-related mania itself works for lithium, valproate, but the evidence for lamotrigine in mania is very low. This is the area I wanted to talk. Cognitive rehabilitation now is intended to improve everyday function by reinforcing, strengthening or restoring previously learned patterns of behavior and or developing new patterns of cognitive activity or compensated strategies. Now this is why actually I thought of, rather than showing, one area that actually we have not handled very well, but actually in our Diga Center, we have started doing cognitive rehabilitation for dementia persons. It not only improve their functional capacity, improve their well-being, but even cognition. We are doing small scale. Our occupational therapists have been trained, and we do reminiscence therapy as well as rehabilitation. We usually buy available puzzles and other building blocks and things that are used in preschool, but they actually work very well. We have seen with the cognitive rehabilitation, you can actually very easily look at how cognitive rehabilitation of elderly are done in YouTubes now. Anyone who, a lot of psychiatrists and trainees, you are interested in elderly cognitive rehabilitation, it's not a big thing. All you have to do is read after assessing the patient and carry out, plan it and do it. And so it has to be done in a very organized and structured manner, that and making sure that the families and the patients are not bored. They can get easily bored. I remember Dr. Jayan Mendis, who started rehabilitation in Angod, is here. I'm thankful that we have taken it more forward to the old date. It works. Now, then there was a argument sometime that rehabilitation done for schizophrenic patient usually lasts less than 6 months. That is also true for old age. Cognitive rehabilitation and rehabilitation-like activities have to be continued for the rest of their life. So any evidence, the evidence for cognitive rehabilitation and rehabilitation of patients for major mental illnesses like schizophrenia and other neurodegenerative, they don't last longer. So this is the challenging area. So we had to continue to advise them to read, engage in social activities, play, social interaction. So training, this is the challenge. But I think we are successful. We are managing the patient. And then compensated techniques. You all are aware, So by the time that they will be presenting you to, some of their cognitive dementias were significantly damaged to a level that rehabilitation is not feasible. So to overcome those issues, compensatory technique can be told, like using memory cards, calendars, boards, and rails. So it's actually, I'm not going to detail. There's good evidence. Compensatory techniques also help survival and reduces hospital admissions and clinic visits. So these compensatory technique and cognitive rehabilitation are best done at home actually. If you look at, because there are a lot of trainees here, I thought of hospital-based cognitive rehabilitation has lesser results compared to the home-based. So this is one argument that we should take out, this learning of giving rehabilitation to the community actually. We should start sending up occupational therapies, community nurses, and giving more. And restorative techniques. The restorative techniques are quite expensive. This is what very high, I didn't show you because I thought the time constraint. Restorative techniques are well planned, the cognitive domains have to be identified, and specific tasks to improve the neuroplasticity of that area has to be carried out. Now, computer-based restorative techniques are done by few neuropsychologists in Sri Lanka. I'm sure you will be there in private hospital, they are done. But we have not really embarked in our government clinic because of the financial issues and facilities. But again, these things are kind of very restorative techniques, evidence base is minimal, but the case histories, centers with good results are rampant all over the world. It's the dedication of the team that actually yields good results in this area. So ladies and gentlemen, I'm actually coming to the end of the talk. Everybody talks of pharmacotherapy. But you will see that when you are managing dementia, right? When dementia is a progressive disorder, treatment starts stopping. And to make sure that you become helpless, you should embark cognitive rehabilitation, compensatory and psychosocial measures from the beginning of the treatment. And there's good evidence and good clinical experience to support that. Thank you very much.
Thank you, sir, for that excellent presentation. Because we have very limited time left, we will welcome just one or two questions from the audience.
Just a question.
Yes. Now this is a tricky area. You all are aware that some of the acetylcholinesterase inhibitors will start licensed for Alzheimer's. But then recent evidence said that there are a large number of mixed dementias. Right? Even mixed dementia, they works. Because the risk factors for vascular dementia and Alzheimer's are same. And research world is a bit artificial, so in clinical practice, sometimes starting, where for example donepezil, actually it improves the functionality. Now, though when you read meta-analysis for systematic review for memantine, it's recommended for moderate to severe or end-stage dementia. But there's good evidence again, from the practice-based evidences, it is not so. So now the recommendation is not to stop the donepezil or rivastigmine, but then to add on. So I agree with your question. I have seen many cases where without even cognitive assessment, where there are good history taken, sometimes people start. Then I have very few evidence to augment, Shahan will agree, whether donepezil can be used to augment memory functioning in late onset depression. This is a dodgy area, I guess. Just because there's case reports, these are very new developments. And I have seen the trend I am witnessing. I would say if there's a real direct benefit of functionality, we may have to continue it. Sometimes you end up now this is the area that I recently had a debate with the physicians and neurologists. They said, okay, you start treating depression. After a while, the functionality does not improve. That's the point we have to actually, in depression, start the assessment for dementia. Comorbidity is the norm in old age. Though we have learned depression, dementia, psychosis, separately, it does not happen in real world. So a lot of these cases are actually comorbid cases. I personally have managed a lot of cases by adding memory enhancers. They do well. And it makes worse actually. I didn't go to that detail. Late onset depression is the prelude to dementia. And if you do functional neuroimaging or a MRI, you will see a lot of periventricular ischemia in late onset depressions, and specifically in very late onset, that is above 75. And they recommend all the cardiac rehabilitation supplements, the antioxidant cascade. This is a big area, very costly and troublesome. I can see some of the pharmaceutical companies have come here targeted with that molecules. Here, so, but they do work. Emerging evidence for the antioxidants and the cardiac rehabilitative molecules to work on the brain vasculature is good. And that's why the vascular dementia management is a science plus art. It was a good question. Thank you, I think.